morning, everyone. On behalf of Team OSN 2022-23, I, Dr. Saurabh Mundhada, Editor Chakshu, welcome you all to the latest series, Chai Pe Charcha. As we all know, OSN is constantly adapting to modern technology. So, with this new avatar of Digital Chakshu, with the aim that what eye sees, mind remembers, we hereby present you video-based versions of surgery, investigations, or manuscripts in video form for better understanding and quick learning. Hope you all savor the taste of this video-based program with a sip of tea. Let's start. Today's topic of Chai Pe Charcha is implantable collamer lenses, commonly called as ICL. As we all know, ICL started with surgery for those patients where LASIK or PRK was not possible. Basically, that's become a substitute surgery. But soon, with progression, it became an alternative to LASIK laser surgery. With the recent advances in over a decade, now they have become a favorite surgery among many surgeons. We at Team OSN feel very happy to invite our national star faculty to talk on this topic and give us nitty-gritties of this surgery. I hereby invite Dr. Rajesh Joshi sir, our national stalwart speaker. He is also head of department GMC Nagpur. He is scientific committee chairman WAS. He was secretary for MOS and also president of OSN and WAS. He is a very enthusiastic, dynamic, and a very renowned speaker all the faculties. And we will request him to share his in-depth knowledge of ICL surgery so that it will help all the general surgeons practicing ICL surgeries. Over to you, Joshi sir.
Thank you, Dr. Saurabh. That was a wonderful opportunity and an initiative by OSN. I really appreciate this initiative. And to begin with, I will share my videos on ICL. You can perform ICL surgery on topical anesthesia or whatever anesthesia you are comfortable with. The side port incisions are very important, one on the superior side and the other one on the inferior side if you're operating from the temporal side. Make 2 incisions and inject some lignocaine, which is preservative free, and the viscoelastic. You should be comfortable with your 2 side ports. If you wish that your manipulator do not go through the incision, you can enlarge this. Make 3.2 incision. If you have a 2.8 incision knife, you can enlarge a little bit. Place, this is the IPCL by Care Group. They have special cartridge for the placement, which is used for injection of the intraocular lenses. Place it properly inside the cartridge. Make sure that the optic and haptic do not catch inside the flanges of the cartridge. Place it properly and move it little bit inside the cartridge. Make sure that it moves properly inside the cartridge. Once you are sure that it moves properly, place it into the injector system. Hold the globe with the help of the side port at the side port and inject the IPCL. As you see, the leading haptic on the right side having a hole, and the orientation is proper. Once it goes inside, with the help of manipulator, you can manipulate the implantable contact lens behind the iris. Once you are placed properly, remove viscoelastic either with the help of the Simcoe's cannula or with the help of bimanual irrigation and aspiration. Make sure that there is no viscoelastic between the natural lens and the implantable contact lens. Some surgeons, they prefer to inject pilocarpine after the placement of implantable contact lens, but I usually don't put pilocarpine. Don't inflate the eyeball too tight. Make it little bit on the shallower side and hydrate the probe properly. I will share my second video Again, place the side port incisions on the superior and inferior side. Inject viscoelastic, make 3.2 millimeter incision. Now, the implantable contact lens has specialized type of system for the placement of ICL inside the eye. They have this cartridge, fill with balanced salt solution and place some viscoelastic. With the help of soft tipped applicator, remove the ICL from the bottle and place it inside the cartridge. Make sure that you orient it properly. The convex part faces the corneal endothelium. With the help of the specialized forceps, catch hold of the anterior part of the ICL and little bit move the cartridge in the backward side. Don't move the lens. Now place this soft tip applicator inside the injector system properly and place the cartridge into the injector system. Lock it properly once you place the cartridge. Once you are sure that lens moves, then again put the speculum, inject the viscoelastic and inject the ICL slowly. Take your own time while injecting the ICL. The haptic which has hole should open on the right upside. As you can see, I have 23 gauge cannula over the haptic and the ICL is opening properly inside the eye. Place some viscoelastic and with the help of this manipulator, put the haptic behind the iris. As you can see, this ICL has got central hole also, which is very important for the drainage of the aqueous from the posterior to anterior part. So once you have placed ICL properly, remove the viscoelastic either with the help of the Simcoe's cannula or with the help of eye irrigation aspiration cannula. Hydrate this port and you are done with the procedure.
Excellent surgery, sir.
Thank you, Saurabh.
You have already explained very simplified way both the type of lenses available. We have a few questions asked by our audience in the chat box. I will on their behalf asking you one by one those questions, and I will request you to solve few simple queries.
Sure.
First question is, what are the best cases to start with?
Yeah, this is very important for the beginners. For those who are performing cataract surgeries routinely and implanting IOLs by an injector system should not be a problem during injection because that is the most important part. For beginners, I recommend selecting a case having an aqueous depth of 3 millimeter and more from the endothelium with the refractive error in the tune of 10 to 12 diopter, because as the refractive error increases, the thickness of implantable phakic IOL also increases. Do not select hypermetropic eyes because they may have a shallow anterior chamber, and in these eyes, it may be difficult to manipulate these lenses. It is always good to sit with representatives of the company to understand the nitty-gritties of implantation, because as you have seen, there are two types of injector systems which are available with the two different types of manufacturers. Avoid cases having anxiety because these people, they move eye during the procedure, and sometimes if something goes wrong, your injector system may touch the lens and may cause problem.
So other than AC depth, any other criteria to exclude the case?
Now, apart from this, the patients having narrow angles on gonioscopy, particularly with bowing of peripheral iris, Because what happens with peripheral bowing of the iris, you create a section, the iris will start coming out. So these cases should be avoided. And aqueous depth less than 2.8 mm, hyperopic eyes and endothelial cell count of less than 1800 per square meter. These cases should be avoided.
So what are your age criteria for implantable polymer lenses?
The ideal age is 21 to 41 years of age for the reasons everyone is aware of. Because at this age, at 21 years of age, the refractor stabilizes. And after 41 years of age, usually there are some changes in the eye which occur, like development of the cataract and other diseases. So this is an ideal age wherein the patient may have spectacular free vision due to high refractive error.
Sir, nowadays most of the companies have came up with central holes. So what is your experience with PI requirements and modifications, if any?
Yeah, nowadays, as you have rightly said, most of the implantable phakic contact lenses have central port or opening, due to which PI may not be needed. But if you see that eye is having very shallow chamber or peripheral bowing of the iris, in such cases, you may need to have an additional opening in the iris apart from the central port of implantable phakic lenses.
So in such cases, will you prefer a laser PI pre-op 15 days prior or on-table surgical PI?
I will prefer to have peripheral iridotomy by YAG 15 days prior to the procedure.
So most important question about ICL sizing. So vaulting, as it is depend on all ICL size. So I will like to comment you on vaulting for first part, and second part, what method you personally choose for calculation of white to white.
Yeah, can I take vault first or an eye sizing
Yes,
or
yes, sir.
whatever?
Vault first.
Vault first, yeah. Vault is an important part of the post-operative follow-up and post-operative visual outcome in these cases. Oversized and undersized ICLs have their problems. If your white to white readings are perfect, company usually calculate to you size of the ICL, and that is usually not a problem. Oversized ICL may lead to pupillary block, glaucoma, crowding at the angles with iris shaping, and resultant loss of pigment. A laser vault is associated with anterior subcapsular cataract. Now, these companies who are manufacturing these IOL, they have nomograms which are available for the supply of implantable phakic contact lenses. To select correct ICLs size based on which is white to white measurement and anterior chamber depth from the corneal endothelium to the crystalline lens. The method used for ICL sizing is FDA approved, and wherein external white to white horizontal distance with help of calipers and anterior chamber depth by Scheimpfling photography was used. Now, in my practice, I usually take readings of white to white on biometer, optical biometer, then on Castrovisual caliper, and then the digital caliper. So I usually take these three readings and supply this to the manufacturer. And accordingly, they guide about the sizing of the ICL. Now, as far as vault is concerned, the ideal vault is around 250 to 75 micron, and it should be half of the thickness of the cornea, that is pachymetry.
Sir, what are the complications you generally face post-operative and particular importance to IOP management post-operatively?
Yeah. Post-operatively, I faced inflammation in few cases, so I may have to give anti-inflammatory agents for longer period. I usually prefer swab steroids for these people because in these high myopes, you never know. You have to keep in mind the steroid responders. So if you are following these patients, you may have to follow them frequently, like 2 weeks, 3 weekly for IOP management. In one case, I had to realign it because patient had big sulcus and there was a rotation of the ICL vertically, so obliquely, I would say, and I had to realign that. But most of the patients were fine. These ICLs usually do not have a problem. One patient had anterior subcapsular cataract, but the visual acuity was good, so the ICL wasn't removed and the cataract wasn't operated. Patient is still under follow-up.
So what is your tip for if in case we need to remove the ICL? What needs to be taken care of while performing a ICL extraction surgery?
ICL extraction surgery, right? Usually the incision which is there, like clear corneal temporal, the same may be used of 3.2 size. Then place some high molecular weight viscoelastic into the eye, then remove the haptics of the ICL as you have placed while implanting this IOL into the anterior chamber, and with the help of forceps, which has got a firm grip, you can just pull out the ICL from the eye. Usually not a problem. You not have to cut this ICL and remove because it is a soft material. It comes out like that only.
So one out of the league question related to IOL power calculation. So I will be asking that if you are ready, I will ask it. So
Yeah, sure, no problem. No problem.
So one last question from chat box. How to suppose these patients are on ICL and a long time have passed and now they have developed a cataract. So we need to do IOL power calculation for such patients. So your tips for that.
Yeah, IOL power
How to
calculation.
proceed with the case where ICL have been implanted and now scheduled for a routine age-related cataract surgery.
Yeah, IOL power calculation is not a problem in these cases, and the best modality is by biometry. And if you are using like immersion contact lenses or applanation devices for calculation of the IOL power, you may have to correct the wavelength of the waves which are passing through the ICL. There are some correction formulas which are available with companies. So if you add this formula to your final axial length, they usually give a correct IOL power. But with biometer which are available, there may not be any problem for the calculation of the IOL power.
So I think this was the last question from the chat box. So
Yeah.
this is the end of the session. I very much thank Dr. Rajesh Joshi sir, our national speaker, for enlightening us in detail with his excellent video presentation, and giving us all the tips about ICL surgery and also patiently solving all the queries. Thank you, sir. To the audience, we will be having a Google form. If any more queries are there, you can write on this Google form and we'll definitely make those form reach sir, and whatever your queries will be, we'll make sure that we'll get a solution to that. Thanks everyone for patiently listening.
Thank you, sir. Thank you, everyone.